Hello, everyone. Welcome to our panel discussion for HSR UK's 2020 conference. My name is Charlie Colgate, and I'm a research manager at the Health Foundation. Today, we're going to be talking about increasing continuity of care in general practice, focusing specifically on the interplay between research and improvement. A few years ago, the Health Foundation designed a funding programme to support a series of improvement projects in general practice. And the design of the programme it was heavily informed by research, and we have also commissioned 2 evaluations to sit alongside the programme, which will generate evidence and learning as well. So today I'm joined by 5 speakers. 4 of whom are connected with the programme, who are going to be sharing their experiences of funding, researching, and implementing improvement initiatives. They'll also be sharing some early stage findings that are emerging from the programme and associated evaluation. I anticipate discussions today to touch on topics such as access versus continuity, the challenges of evaluating complex improvement programs, conducting research in primary care settings, and the importance and challenges of delivering continuity in light of the COVID-19 outbreak. We will now hear from our 5 speakers, and we will also finish this session with a Q&A. So without further ado, I'll hand over to Angus Wiltshire, who is Programme Officer for the Health Foundation's Increasing Continuity of Care in General Practice programme. Over to you, Angus.
Thanks, Charlie. As Charlie's mentioned, I'm a Programme Officer at the Health Foundation. I've been supporting this programme now for over a year. I wanted to start a session by giving a bit of a background to the programme and a bit of an overview. The programme was inspired by recent Health Foundation research, which demonstrated that patients with ambulatory care sensitive conditions who saw the same GP a greater portion of the time had fewer ambulatory care sensitive emergency admissions. Off the back of this bit of research, we were keen to design a funding programme to test how continuity can be improved and to see what different methods work. The focus of this was initially around relational continuity of care, which we early on defined as the same professional seeing the same patient over a period of time. We received an enormous amount of interest in this programme, actually, which is a really positive thing to see that so much interest out there in improving continuity of care. We had over 120 expressions of interest and selected 5 projects, which all began in January 2019, running for between 18 months and 2 years. The programme, we have a support partner, which is the Royal College of GPs, who help deliver some of the learning events and the online community of interest. And we, as Charlie mentioned at the start, we commissioned 2 separate evaluations. And you'll hear from both of those evaluators later in this session. On the next slide, you can see an overview of the programme itself, just touching briefly on the different project sites themselves. I think what stands out is there's a real range in the sizes of the projects themselves and the approaches they're taking. There's some large-scale projects such as One Care in Bristol and South Cumbria, who are approaching continuity at a really large scale, over 24 practices at One Care, but then also sharing it with other GP practices within their GP federation. And within those large projects, each practice is taking a slightly different approach. That can also be seen at some of the more medium-sized projects such as Peer Health and St Leonard's. And then we have one project which consists of a single GP practice, which is Valentine Health Partnership in Woolwich, London, who are taking a slightly different approach, and they're using data analysis to predict patients who will benefit from a period of elevated continuity and targeting an extra level of continuity of those patients. I also wanted to briefly, obviously, I've outlined there that there's a real range in the sizes of projects, the different approaches that practices are taking themselves. And I thought then I'd touch a bit on the approaches they're actually doing, such as, I think, actually consistently across the programme, the sites are focusing heavily on measurement as a kind of starting point, that you need to be able to measure continuity in order to improve it. There's a lot of different approaches to communication and engagement with patients, with GPs, and with other healthcare staff. There's been some real impact from engaging early on with reception staff. They can have a real impact on the levels of continuity that are experienced in the practice. Some sites are using matching tools to match patients to GPs to help spread the workload evenly between GPs to support high levels of continuity. Some sites are trialing using team working. So these are called micro teams often is one approach, in which a group of GPs operate as a bit of a buddy system and potentially with other healthcare professionals, so that if the named GP isn't available, another GP can step in and offer an element of continuity. And then there's a large range of local actions that individual practices are taking that vary practice to practice and often involve quality improvement methodology. On my third and final slide, I just want to give a kind of a bit of a flavour of the programme itself. We've held 2 learning workshops and great opportunities to bring all the award holders together to support peer learning, to start to develop some potential programme outputs. There's an online platform which you're welcome to join if you want to get in touch, which is hosted on Basecamp, which functions a bit as a forum with that wider community of interest. As I said at the start, there's been a lot of interest in this programme through expression of interest and also through a broader community of people who are interested in improving continuity. We also hosted a programme webinar in November, and that's recording of which is on the RCGP YouTube page. So if you'd like to learn a bit more in detail about the programme itself and hearing from some of the award holders, that'd be a great place to start. And finally, obviously COVID-19 has impacted on this programme and impacted on continuity of care. We've heard from some of the award holders that it's particularly highlighted the importance of continuity, the importance of having existing relationships with patients, and especially with remote consultations as an example. We've heard from quite a few of the award holders that it's been really valuable to have that existing relationship before you end up moving rapidly to an online remote consultation. Obviously, COVID has also impacted on the timelines of the projects. So we have paused the programme at the moment for 6 months, starting from Easter. This is to give the teams time to focus on their COVID response. Some of the teams are completely frozen. Some are doing as much as they can around their obvious primary focus on COVID-19. And that means that 4 of the award holders will actually now finish in July 2021. So that's all I wanted to cover in this first bit here. So I'm going to hand back to Charlie.
Thanks very much, Angus. So next, our next speaker is Sir Dennis Pereira Gray, and Dennis has worked as a GP in the St Leonard's practice in Exeter for over 38 years. Over the course of his career, he has become Professor of General Practice at the University of Exeter, President of the Royal College of General Practitioners, and Chairman of the Academy of Royal Medical Colleges. Dennis is also one of the award holders of the Continuity of Care programme. Dennis, over to you.
Thank you very much. Well, I'd like to thank the Health Foundation for inviting us to speak on this. It's a fascinating topic and we're very grateful and pleased to do so. And I'm speaking, as you've just said, as one of the 5 pilot sites which are experimenting with different ways of improving continuity in this important project. We started with the issue of the definition, and we think it's very important to have it as simple as possible. And as the Health Foundation stipulated continuity of GP care initially, and that's what was the bid was for, we've simply defined it as repeated consultations between a patient and the same GP. The big issue really is that there is a huge amount of research now which shows a wide range of benefits for patients and for GPs and for the health system from continuity of care. And not only are they a large number of benefits, but they are particularly important ones. For example, patients are significantly more likely to be satisfied, they're more likely to follow medical advice, they're more likely to adhere to prescribed medication, they're more likely to take up personal preventive medicine like cancer screening and immunizations, they're more likely to be enabled. That means they're more likely to be able to look after their own conditions, whatever they may be. They're more likely to receive better quality of care. They're less likely to go to A&E departments. They're less likely to be admitted to hospital if they're elderly and have ambulatory care sensitive conditions. And now, very recently, we have discovered that they are less likely they're likely to have a better mortality rate, to die less often. The first systematic review showing that was 2 years ago, and now we have a second one coming out in the next few weeks, which shows that for primary care staff alone. So that's a colossal range of outcomes, and they are some of the most important things in medicine. In fact, you could say they are the most important things in medicine, because those are the things that determine quality across the board. It's always said that these are studies that are observational. That is to say, they are not based on randomized controlled trials, and this is absolutely true. However, there are several reasons for believing these findings, because first of all, the big cohort studies are devising extremely sophisticated ways of adjusting for variables and to remove the problem of confoundings. And secondly, there's a very interesting feature about continuity, which is that patients can lose it. And that sets up situations where you can study the loss of continuity the other way around. And this turns out to be very powerful, and it gets rid of quite a number of the confounding problems like reverse causality. And there are, in fact, 1 or 2 randomized controlled trials. There's a very old one in the 80s, which was possible. And there are several analogous ones in midwifery, where they're showing loss of losing children as high as 16% in only 6 months. So I think we have to work on the basis that this is a colossal finding, really important, but not very well known. And we have to find ways of spreading this very important information so that working practices understand how high the stakes are. So this leads directly onto the question of measurement. And the real sad fact is that most general practices don't measure continuity at all. So that most of them don't know what they've got. Most of them don't know whether it's any better this year or last, or even if the trends are getting better or worse. So that an overriding issue is to find ways of helping practices to measure it. There are actually several ways of measuring continuity, and several have been described in various articles. And I think the main message today is to measure it one way or another. That's a matter of choice. In Exeter, we much prefer the measure called the SLIC, the St. Leonard's Index of Continuity of Care, because it's 40 years old. It's been used in practice successfully for that time. It was devised inside a general practice to make the thing as easy as possible. And it gives working GPs and their staff useful information within 3 months. It is the most inclusive measure. It doesn't exclude large numbers of patients, as some of the other measures do. It includes every appointment with every patient all the year round. And that's theoretically quite attractive. The real issue is helping practices to value it, because in a hassle of day-to-day, and if you don't know what's happening anyway, continuity can just slip away by default. It's in fact going to go out of practice. We're going to lose it if we don't do something possible, because there's overwhelming research that the bigger the practice, the worse the continuity. And practices are getting bigger and bigger. So we have to take some active steps. One of those steps is to have a system in which the patient is given a personal doctor or a named doctor, which is actually a requirement of the NHS contract, that every patient should be given this, and then simply to encourage wherever possible that patient to see that doctor. It's not going to be possible a lot of the time because, of course, GPs are working part-time. Probably the majority of GPs are now working part-time. So there will be days when the relevant GP is simply not there. There are mechanisms like buddies and micro teams which can make some sort of compensation for that. And there are a number of very exciting systems in the Health Foundation project which are looking encouraging. The real question is what's possible and what does good look like? We are awaiting the results from the Health Foundation, and one of its greatest achievements will be to produce, I think, some practical examples of how much is possible. We're very encouraged to hear from some of the other sites, not ours, that they're talking about 90% achievement between patient and doctor, the GP the patient wants. We are not anywhere near that in Devon. Our figures are around a group of general practices that we're in close touch with. Around half of all appointments over the year are with the named personal doctor. But the encouraging thing in our setup is that we have practices where 65% of all the appointments of all people aged over 65 are with their personal doctor all around the year. And as most of the multimorbidity is in that age group, this is encouraging. But I think we will probably have, from the variety of projects in the Health Foundation, a much better understanding of this in a year or so's time. Thank you very much.
Thank you very much, Dennis. I'm going to hand over now to Emma Torrents. And Emma is a principal consultant at McDonald. And she's also one of the program evaluators who is leading the mixed methods evaluation. Over to you, Emma.
Thank you, Charlie. So yes, as you say, I'm the project manager for the mixed methods evaluation, where together Mott MacDonald and the University of Manchester have worked in partnership in terms of pulling together this approach and our findings. So the main overarching evaluation question is to understand if and how the improvement approaches can be used to increase continuity of care. So these evaluation questions have been stratified into 3 categories: patients, workforce, and the system. And to answer these questions, we use, of course, mixed methods through surveys and interviews and focus groups with patients and staff across the 5 project sites. We've also included observations from the learning workshops, seminars being undertaken within the project sites themselves, and also attending steering groups. We've also looked to include information reviews for locally collected data, but I think it's very important that we include and are aware of the local context in which this data is captured and applied. So one of the first areas of interest that we had for the mixed methods evaluation was to gather a baseline and understand how important continuity of care was deemed to be. And in truth, I think what we had first captured thinking, we'll have a look at what the baseline is, and then in theory, over time, through different patient education, staff education, and changes being made locally, that perhaps that importance would increase when we go to review at a summative point at the evaluation. However, within the baseline itself, we found some really interesting insights. So when we asked patients to rate how important continuity is to them, 54% of patients deemed continuity to be very important. However, when we asked GPs, only 16% of GPs found continuity to be very important for all patients. And this is less when you compare to their general practice colleagues from the wider clinical teams and the management and admin teams. However, we then tried to drill down a bit further and think about, is it just because of we've posed the question to all patients? Is it that continuity of care would have increased importance for specific groups or cohorts or characteristics of patients? And that's very much what we found, that when we posed the question, sorry, Charlie, could you move to the next slide? Thank you. That viewpoint does change when we ask for a specific group of patients. There's a much greater alignment between the workforce. And again, when we delve further into asking what those groups are or what characteristics these may be, where patients are deemed to have an increased importance for continuity. These purple bars on the side here give us some indication. Of course, there's interdependencies between these characteristics, but these are described as those with long-term conditions, perhaps those with chaotic lifestyles through substance misuse, or those who have more social issues or be deemed to be vulnerable. And I think this data typifies the complex nature of how staff view the importance of continuity of care. And this transcends beyond staff, and actually also the complexity of these views were shown through patients too. We had discussions with patients where we could see that there were occasions where the importance of continuity was perhaps more emphasised in episodic areas of care and highlighted by the pink bubbles. Sometimes they were linked to the conditions. So looking at the orange bubble on the right-hand side, we can see that this lady had said that she wanted to see the same GP for her mental health, but for other conditions such as her asthma, it was less important for her. There's also patients who describe that longitudinal, traditional family doctor role for continuity, where they would like to see their GP for every single appointment. There are some who perhaps it's less about the relationship that they have or with that GP, but more about the specialist interest or skills of the GP itself. And of course, there are others who recognise that continuity may not be important to them now, but recognise that it could be something for the future that will be important to them. And how, when we reflect upon that as an entire view of how continuity may wax and wane over time, I think is a very interesting and complex viewpoint. And moving beyond this, we also wanted to understand what that perceived impact of increasing continuity of care would be in general practice, both positively and negatively. And again, we spoke with patients and staff with the aim to capture it at baseline level and then reflect back at the end of the evaluation to understand what has been realised in practice. And for those of you who have a solid footing in the literature of continuity of care, I'm sure very few of these will come as a surprise. But I think it was just interesting that we still have that consensus from our engagement. So just a quick example is that having that better knowledge of a patient and their history was described very strongly from both patients and staff, where for patients they felt that having an increased continuity allowed them to start from the middle of their story, not from the beginning. But of course, again, when it comes to the consequences, there was that perception that to increase continuity, you would have to forego access. And that is that age-old shifting scale, and whether it is that is for something for discussion. And then looking back to the system, that by having increased continuity, you can reduce hospital admissions and attendances, which of course was the catalyst for this programme in the first place. So for our next steps for the mixed method evaluation, we're looking to undertake a second wave of engagement to understand whether continuity of care has increased from the baseline through the changes being made locally in the practices, understand what the critical success factors are to enable and support these changes, understand what impact the programme has had on patients and on staff, and what, if any, of the perceived benefits and consequences have been realised in practice. But of course, we have to be cognizant of the current climate, and given COVID-19, we must consider how these insights that we've gathered to date may change over time and acknowledge the shift in priorities in general practice. Thank you.
Thank you very much, Emma. So to hand over now to Therese. So Therese Lloyd is a senior statistician within the Improvement Analytics Unit, which is a partnership between the Health Foundation and NHS England and NHS Improvement. And the IAU provides robust quantitative evaluations of complex changes within the NHS. So Therese, over to you.
Thank you, Charlie. Hi, everyone. So I'm going to talk to you a bit about the quantitative evaluation. Charlie, if you can move to the next slide. So the aim of this evaluation is to explore if the initiatives that were implemented as part of this programme changed continuity of care between patients and their GPs, and if so, for whom and in which circumstances. And we'll also be looking to see if the initiatives affected how often patients have contact with their GPs and what methods of contact. So does it make any difference to whether they need to see them face-to-face or not? As mentioned earlier, there are several different approaches that are being taken across the different project sites. And so we'll be evaluating each approach separately, as well as evaluating the whole programme as a whole. And we'll also be looking at specific subgroups of patients who may value or benefit differently from improved continuity of care. This could be, for example, those who've got 2 or more long-term conditions or have mental ill health. And this list is based on several different sources, one of them being the mixed methods preliminary results. Also, from speaking to patient representatives, as well as speaking to the sites themselves and looking at which groups they are particularly targeting or interested in. What we ideally want to do is to we want to be looking for whether the interventions made a difference to the outcome. So we're looking for a causal effect. So ideally, we would be comparing what happened. We'd be looking at the patients who received the interventions, and then we would be comparing them against what would have happened if they hadn't received the intervention. Now, that obviously isn't possible, but what we can do is we can try and replicate that comparison group by choosing a very carefully selected comparison group. Charlie, if you can go to the next slide, please. Now, what we're aiming to do is to find a comparison group that as much as possible resembles the intervention group. And what's important is that they are similar on the things that will affect the outcomes that we're looking at. So in this case, we're looking at continuity of care, for example, and we know that that's likely to be dependent on how often you go and see your GP generally. It's also likely to depend on what long-term conditions you have or how many long-term conditions you have. But as well as the patient characteristics, there's also characteristics of the GP practices which will affect the ability to improve continuity of care. And that will, for example, be the practice list size or how many of your GPs work full-time or part-time. So what we do is we find a matched control group, which is our counterfactual, that resembles the intervention group on as many of those characteristics as possible, so that we're comparing like for like. And then after we have found our comparison group, we compare the outcomes after the implementation. And that gives us a sense of that gives us an estimate of what the difference would have been due to the intervention. To be able to do this, we need a lot of data. We need a lot of information. And if we were to, it's not just on the intervention group, it's also on the pool of potential control patients and practices to be able to find those that most resemble them. So if we were to collect that data ourselves, it would be a mammoth task. So what we do instead is we can get access to GP records. It's all pseudonymized, so names, addresses, full dates of birth, NHS numbers, all of those have been removed. In the case of NHS numbers, you get a pseudo ID instead, so that you can't identify patients in your data. And we can use this to do our analysis. Next slide, please. So I was talking about our main outcome is looking at whether there's improvement in continuity of care. There's lots of different ways of measuring continuity of care, as previously mentioned. The first decision is, of course, what kind of continuity of care are you trying to measure? In this case, we're looking at longitudinal continuity of care, so that's how often you see the same GP or have contact with the same GP. And we're specifically interested in GPs, so not all healthcare professionals. But even within that, there are lots of different ways of measuring it. We're using two different measures. The first one is the usual provider of care index, the UPC, which basically just measures the proportion of contacts that were the proportion of contacts with a GP that was with your most frequently seen GP. The other measure that we're using is the Weiss-Boxman continuity of care index, which looks at this, but also takes into account how many different GPs you see. And that's particularly of interest because some of the practice sites are using GP buddy groups. And for both of these measures, we're looking at any meaningful contact between a GP and a patient. So that can be at home visits or face-to-face in the practice, video consultation, telephone calls, even email or text message. We'll have to look, when we get the data, we'll have to look and make sure that data is reliable to be able to use, but that's the plan. And as a sensitivity analysis, we will also just be looking at contacts that are either face-to-face, video, or telephone. Next slide, please. So the advantage of this kind of evaluation, so having a matched control group like this, having a counterfactual analysis, is often more reliable than, for example, before and after analysis. And using routinely collected data from GP practices also has the advantage of providing us with a lot of information, both for the intervention sites, but also for a large pool of potential control patients and practices. And also it allows us not to be reliant on patient recall. For example, if you ask me how many times I went to see my GP last year, I don't think I'd be able to give a very accurate number. Next slide, please. There are, however, some limitations as well. One of them is, of course, that we are limited by the data that we have access to. So we don't have necessarily access to some of the things that might matter to patients, so quality of life or patient satisfaction. The other thing to bear in mind with is that this data wasn't collected for research or evaluation purposes. It was collected, recorded by GPs or other healthcare professionals to help with the care of patients. And so especially some of the data fields might not be reliable. So we have to be very careful when we use the data to make sure that we use it in a sensible way. The other thing is, as I was telling you about having a matched control group, is the idea is that you compare like for like. And the only difference between the groups is that one group got the intervention and the other one didn't. And that's how you can attribute any difference in outcomes to the intervention. But of course, this program wasn't implemented in a silo. It was implemented at the same time as there were other changes within primary care, most notably maybe the primary care networks, which involves other healthcare professionals joining the teams and maybe doing some of the tasks that GPs would have done in the past, for example, pharmacists. There's also the enhanced health in care homes, which is being rolled out across care homes, which hopefully will mean that care home residents will have better continuity of care with a GP. If this was being implemented the same across the country, that would be fine, because we'd still be comparing like for like. But the problem is, of course, that different areas and practices are at different levels of maturity when it comes to these changes, which makes it more difficult to compare. And then, of course, we have COVID-19, which again will be affecting all primary care, but the impact may again vary between areas and practices. And we also have the additional problem of having had this pause in the implementation of the program. So we're going to have to take a step back and reconsider how best we can do this evaluation while still having robust and reliable results. Thank you.
Thanks, Therese. So now I'm going to hand over to Professor Chris Salisbury, who is Professor of Primary Care at the Centre for Academic Primary Care at the University of Bristol. He's had a long-term interest in continuity of care and has published a number of papers on this topic as well. So I will hand over to you, Chris.
Thank you, Charlie. I think it would be helpful just quickly to recap where we've got to. Angus reminded us that there was a lot of interest in this program, so continuity is clearly still important to many general practices. And yet, on the other hand, it's important to bear in mind that other studies have shown that continuity is declining very fast, and that's partly a response to policy. And Dennis pointed out that there are clear and multiple benefits from continuity of care. Although I would say that the research is not entirely straightforward. Sometimes we don't observe the effects, the benefits that we expect from continuity of care. Some of the studies are mixed, and often the effects on outcomes are quite small. Therese pointed out that it's possible to measure and evaluate continuity using routine data. And she's using a good experimental design to understand the effects of continuity in these practices. She also, her presentation showed how it's important to give careful thought to what exactly is it that you measure and what exactly should the comparison be. And Emma's presentation showed us that continuity is not a simple concept. It's important in different ways to different groups of patients at different times, and the importance depends on why they're consulting. And one thing that was particularly interesting was that continuity now seems to be lower. The importance of continuity now seems to be lower for GPs than it is for patients, or at least for some groups of patients. Thank you. Next slide. And this whole topic raises a number of questions for me. why exactly is continuity important, and why does its importance vary for different patients and for different purposes? And how exactly does continuity of care, how do we believe that it leads to the benefits that we observe and that Dennis has pointed out? And I think thinking this through and being clear about it helps us to ensure that if we're going to promote continuity, we design systems that provide the right kind of continuity and then get the benefits we're after. And if we're doing evaluations, it means that we measure the right things to understand how continuity leads to benefits. Thank you. Next slide. And this kind of theory, this mechanism, often isn't really clearly spelt out, but I think it goes something like this, that if you see the same doctor, that leads to building trust in that doctor. And if you follow through the green lines, that leads to building a relationship and also to promoting adherence and encouraging people to self-manage because they trust the advice of their doctor. And that leads to improved satisfaction with consultations and better health outcomes. Similarly, if you see the same doctor, you don't have to keep repeating the story over and over again, and that could lead to improved efficiency because it could lead to shorter consultations, and that could lead to reduced costs. Also, if you have better trusting relationships with your doctor, you might go to hospital less often, and that will also reduce costs. And also, seeing the same doctor leads to an awareness of the patient's situation, their life context, and that can mean that decisions that the doctor makes are better informed. And that can lead to more appropriate decisions, such as reduced hospital admissions. Next slide. But there are lots of ifs and buts around that theory. What about if we look at seeing the same doctor, it's possible that the doctor you're seeing isn't the doctor you want to see? Will it still lead to the same benefits? Will it still lead to trust? Understanding this theory helps us understand why continuity is sometimes more important to people who've got a complex story to tell. And that might be why. Does seeing the same doctor leading to a relationship mean it always has to be the same doctor, the single same doctor? Something that struck me a while ago that I don't know why I hadn't realized it before is it's possible to have a relationship with more than one person at the same time. My children can have a strong trusting relationship with me, but they can also have a strong trusting relationship with my wife. So maybe the implication in general practice is you just have to have a small number of people that you trust, that you see. And sometimes some patients say they don't really want a relationship with their doctor. It's convenience that they want. So some patients, or at some times, might value convenience more than they value a relationship. And then a final bit of this theory that I think has been underestimated, and Dennis pointed it out, this importance of having a GP is responsible. I think that the relationship is not only important to the patients, it's important to GPs as well. And I agree with Dennis that a really key thing is that there's a GP who feels a loyalty and a responsibility and accountability for a patient. And if that's true, it could be important even when the patients don't realize that it's important. Next slide. So what are the implications for evaluation? Nearly always, evaluations have used longitudinal continuity, measures of seeing the same doctor. And that's what Therese is using in this study. But even that requires all sorts of decisions. Which measure are you going to use? As she said, there's a range of them. There's a whole competing industry of measures for continuity. And which types of consultation are we going to include? Therese mentioned including all sorts, face-to-face, telephone, online, but many other studies have just used face-to-face. Does continuity matter as much for a text message as it does for a face-to-face consultation? And which professionals? I think Therese is focusing on consultations with doctors, but does continuity with nurses matter as well? So there are lots of decisions to make. And the most important thing is that I think that seeing the same doctor is only a proxy for what actually matters. And probably what matters most is the relationship, the sense of responsibility from the doctor to the patient and the trust from the patient to the doctor. And if that's the case, seeing the same doctor is a means to an end, not an end in itself. And maybe we should be looking at patient-reported outcomes, like asking people, did you want to see a particular doctor? And did you see the doctor you wanted to see? And how well does this doctor know you? And how much do you trust this doctor? And if we measured things like that, we might see a clearer relationship between continuity and outcomes. But the key point of all this is that decisions about what we measure in evaluation depend on our theory about why continuity is important and how it exerts effects. Next slide. What about implications for policy? Well, a clear implication is that many practices clearly want to improve continuity, and we know that patients value continuity. One of the great things about this Health Foundation initiative is that it's supporting evaluation, but it's also supporting change. The two things are happening parallel, and maybe that is a lesson for policy. It's clear that continuity matters to practitioners and to patients, but access has been prioritised, and we need policies that encourage continuity. These things are often seen as being in tension and as if having opposite effects, but I don't believe that. I think it's possible that improved access can go hand in hand with improved continuity. And in fact, if you improve access and if that improves efficiency, it might, if continuity improves efficiency, that might also improve access. I've tried to highlight that continuity is important for doctors as well as for patients. I think that is really key to the future of primary healthcare. And a lot of the reasons that people like me went into general practice is because they want to deal with patients as people that they get to know. And if that disappeared in general practice, then I wonder what that will say about future recruitment to general practice. Continuity has got costs and benefits for both parties. Patients may have to give up a bit of convenience in order to see the person they want to see, and doctors may have to give up a bit of convenience sometimes, but many of them value continuity and would do that. And one can't think about implications for policy without saying something about the current situation and the pandemic. And the ways in which remote consultations are implemented could reduce or reinforce continuity. In many places, remote consultations have been implemented on a kind of call center model, and there's been no attempt to continue continuity. But on the other hand, you could implement them. It doesn't have to be like that. You could implement them in ways that encourage continuity, and some of the practices have tried to do that. And some of them have found that if you do have continuity, it actually makes remote consultations easier and more effective because you already know the patient and you've already got a relationship with them. But I think the most important conclusion and implication for policy is that continuity is very important to both doctors and patients, and that we need both research and policy to understand and support it. Thank you.
Thank you very much, Chris. And thank you to all of our speakers as well this morning. I really appreciate you taking the time to provide these insights. So we're going to move on to our Q&A now, and in lieu of a live audience, now that the conference has moved online, we have used Twitter and various other platforms to source some questions to put to our panel. I would very much encourage our audience, anybody watching this video, that if they would like to add to the conversation at all, we hope that the points and the issues that we raise in this, we hope to continue this conversation on social media, particularly on Twitter, using this hashtag here, HSRUKXContinuity. So if you have any comments or further questions, then please add them to the ether there. So to start with a question which came through from Twitter, first of all. So to our panel, what is the optimal appointment system to provide good continuity of care for those who want it and benefit most from it, and good access for those who don't? Dennis, can I ask you to comment on that question first of all?
Well, I think it's a very good question. There are two main systems of organising appointment systems in Britain. There is the combined list system, where particularly common in big cities, where patients are told they can see any doctor they like anytime they come and they choose. And there are systems which have a usual doctor, a named doctor, or personal doctor, whatever you call it, which encourage the patient to see a particular GP. And I think the really big step, which is actually overriding, is to realise these are not the same, and that the research points heavily to the value of having some kind of skew, deliberate skew, to help patients see a doctor consistently. And I think that can be done in a variety of ways. And of course, with new electronic platforms coming in, that may be the future. But even in the old previous system, it was perfectly clear that if a practice wanted to provide continuity, it could do so at reasonable levels. And what really matters is actually the practice should think about it and prioritise it. one of the difficulties that some practices don't really think it's that important, and some practices don't know how much they're doing anyway. So the critical issues, I think, are policy and measurement.
Thank you, Dennis.
Can I just build on that point, Charlie? Because I think that reflecting on some of the work that's been going on in the programme, some areas have been looking to implement Ask My GP as a way to manage demand and provide continuity. So this works by filtering all patients through one system and allows patients to select if they have a preferred GP and who they would like to see for that appointment. So one practice in South Cumbria has shown that the majority of patients do have a preferred GP that they would like to see and can accommodate that in about 95% of cases. But I suppose other sites who aren't using platforms like that have taken a more informal approach, where reception teams who are scheduling appointments can ask the patients if there is a particular GP that they would like to see. And they found this is a way to introduce the conversation to the patients about considering continuity in terms of their decisions of appointment scheduling.
Does anybody have any additional points to note or add on?
I just want to make the point that Chris Salisbury made in his summing up, which is the other side of this, that the doctor the patient wants to see isn't necessarily the GP who feels responsible for them. It's a point that's usually missed, in fact. And I believe the same as Chris does, that the benefits are when the GP identifies with the patient and feels responsible, and just that the patient's choice is only half the story. The other half of the partnership is what's in the GP's mind, and the benefits come if the GP cares.
Thank you, Dennis. So to move on to our next question, we actually had a comment submitted from somebody who is working in primary care, which says, for those of us working at the coalface in practice to provide continuity, there's no doubt that continuity is better for patient care, for GP retention, and for job satisfaction as well. So this person says that they have worked where there are no clear lines of responsibility, and they've really heard from patients about the chaos that can sometimes cause. This person says that they don't necessarily need more evidence of continuity's effectiveness. They want to know more about how we can persuade the right parties to financially incentivize us to do this and to be really showing the benefits. So my question for the panel is, what do we need to do? And how can we be using research and evidence in particular to be creating policy change in this area? So how can we be translating what it is that we now know into action?
Well, I think there are two sets of research that are needed. The first is that there is a shortage of randomized controlled trials of continuity, and I think this needs to be done by academic units. There has been one early one in the 1980s, but we're a bit short on that, and it would deal with the continuing argument about the quality of evidence. I think that should be done as soon as possible. Quite separate from that, there's a much more important subject, I think, which is to how we actually reach ordinary service practices and help them to introduce arrangements that improve continuity. And we're at the very beginning on that. And the Health Foundation is absolutely central. It's the biggest project in Britain. It's got the widest variety of reach. It's got a variety of ways of tackling it. And it's really important that we find out more about how to encourage GPs actually to provide it in a service setting.
Just to build on what Dennis has said, I agree that we need more experimental evidence. Most of the evidence has been observational associations so far. And of course, what the Health Foundation are doing here is trying to provide some experimental evidence, but with an observational design and comparative design, which is definitely a way forward. But I think we need larger studies, ideally randomized. But you can't randomize a practice to continuity just like that, any more than you can randomize them to provide good quality care. You have to randomize them to an intervention, to something specific. So we need to be clear what exactly is the intervention we're going to offer to is it having a named doctor? Is it using a system like Ask My GP? Some sort of intervention to promote continuity and then provide experimental evidence that it makes a difference.
Thank you.
I think also that there's that, as mentioned before, we some more robust analyses would be good, but there is still quite a lot of evidence on associations between improved continuity of care and improved outcomes. What I think is really missing is information about how to improve continuity of care, and I think that that's one of the great things about this program, is that with the different project sites being able to have quite a lot of flexibility on what they do, hopefully we can get some good learnings from that. But I think that the other thing, if we're talking about policy, to me, there was a policy that was implemented in the GP contract in 2014, which was the named accountable GP for over 75s, and that was trying to improve continuity of care in over 75s. The idea was that every person who was age 75 or over would have a named accountable GP who would be responsible for their care. We actually did, in the Health Foundation, we did that evaluation. And we found that, yes, everybody got a named accountable GP, but continuity of care did not improve at all. And I think that was probably a bit of a tick box exercise. And I think that one of the things that was lacking there was maybe also on having that robust evidence and making GPs aware of it, so that they could make their own they could make an informed decision about the benefits of it and why they would want to implement it. The other thing around policy is if we were to do that, we would want to know what is a realistic target, and what is the likely impact of an intervention. And I think, again, that this study can be quite useful in that, although bearing in mind that the practices which are in this program are self-selecting, so they're interested in continuity of care and they received funding to implement these interventions. So they might give us a sense of how much continuity of care can be improved, but bearing in mind that that was under helpful settings.
Yeah, I agree, Therese, and I think that when in that question we were talking about financial incentives, and indeed they have been a useful mechanism for increasing access. But to do that for continuity, you're right, we first need to understand what good looks like and what is achievable. We need to have some consensus of how we measure. And, is that face-to-face contacts alone for continuity, email, giving what we know now about remote consultations? Is that for all patients? Is it for particular cohorts? Is it particular age groups? All of these things, I think we must drill down before we can really get into the more granular level of the financial incentives and trying to influence policy.
I think I just make 2 points. One is that we only seem to think of incentives in terms of money, paying doctors to do things. That's the sort of current frame of thinking. The bigger incentive for a lot of GPs is professional pride and wanting to do a good job, and that is sort of being a bit undervalued at the moment. And secondly, Teresa's point about the experiment with making GPs issue patients with a named GP for the over 75 is a classic example of what I said earlier. It completely ignored the thinking in the GP's mind. So GP practices dished out a name and took absolutely no notice of what the words meant. And no GP was accountable for any of those 75s in most practices, and they just carried on as before. It was, as Teresa has said, a tick box exercise, because it didn't reach the mind of the GPs. So in all of this, it's about building GP responsibility, which is a professional issue. It isn't just about money or rules or tick boxes.
Thank you. I just want to start to draw this session to a close now. Does anybody have any final remarks or comments or challenges that they want to make to anything that they've heard here today?
I think I just want to say that the whole thrust of the whole of the session is that we need to draw into the public arena the findings of these 5 projects. It's really important those are publicly available. I don't, for example, have the figures for several of the other sites in the Exeter wing of the project, and it's really urgent that we actually get some hard figures to see what people can do and how much they can manage using different methods.
Thank you, Dennis.
that we convert that into actionable, implementable guidance for practices about how can they improve continuity.
And that is something that I can safely say as the programme continues. We'll work really hard, the Health Foundation, to make sure that that happens. So anybody watching this, please watch this space, and hopefully we'll have more to tell you in due course. So to be continued. So just to wrap things up, I want to say thank you very much to all of our speakers today, and to all of the people that have been watching this video as well. Thank you.